All right, I think we'll get started. Welcome, everybody. This is our first webinar in our series for the Global Nursing Network for Rare Diseases. My name's Sian. I'll be hosting today's session, but I will be passing over to our wonderful presenter, Zoe Morrison. Zoe?
Morning all. So for those of you that don't know me, my name's Zoe. I'm the clinical nurse specialist for the paediatric arm of the Syndrome Without a Name clinic here in Wales. So I'm just going to talk to you about that this morning. So just some quick facts about rare disease. I'm sure all of you know them, but for anybody who doesn't, there are over 7,000 rare diseases that are currently known, and that list is increasing every year. Even though rare diseases are individually rare, they're collectively common. It's estimated that there's 350 people worldwide, which is 30 million people in Europe and 3.5 million people in the UK who suffer from a rare disease. They're lifelong conditions, they're life-threatening and life-limiting. In the UK, we first published our UK strategy for rare disease 20 years ago, but despite that, there's still significant unmet needs for these patients within the UK. There was a survey a couple of years ago in the UK. There was 1,080 responses from people that either lived with a rare disease or helped care for someone with a rare disease, and 78% of these people said that there was no specialist centre for undiagnosed disease in the UK. And the National Health Service, which is our health service in the UK, it's estimated to cost them £3.4 billion over the last 10 years just on diagnosing rare diseases. So the aim of the SWAN clinic is to shorten the diagnostic odyssey for patients with undiagnosed conditions. We have acceptance criteria, which is patients with involvement of 2 or more organ systems and suspected of having a unifying diagnosis, and we have no age limit. We are a pilot service, which is a 2-year pilot funded from our Welsh Health Specialist Service Committee, and we have just been granted another 12 months extension. We're hosted within the Cardiff and Vale University Hospital, but we are a whole country service. So we cover the whole of Wales, and then at our discretion, we will accept patients from England as long as their care is funded as well. And our patients are discussed in weekly MDTs and seen in face-to-face clinics. So we have a paediatric and an adult SWAN team. We're led by Dr. Graham Shortland, who's our SWAN lead. And then in the paediatric team, we have a paediatric clinical lead, a paediatric genetic lead, a rare disease paediatric clinical fellow, and myself as a nurse specialist. And then the adult team mirrors our setup with an adult clinical lead, an adult genetic lead, an adult clinical fellow, and an adult nurse specialist. And then we are supported by a specialist registrar in immunology, a genetic counsellor, a bioinformatician, and various teams that are needed depending on the caseload each week. So we accept referrals from all across Wales, and like I said, it's for patients with the involvement of 2 or more medical systems and are suspected of having a unifying diagnosis. We can slightly change that criteria. For instance, we have got a couple of children who only have the involvement of one system, but there's clearly a genetic cause, as when we look through the family history, it's present in a lot of family members. We have a weekly combined MDT, and we regularly invite different experts into that. And then we have 3 face-to-face clinics a month. Paediatrics have 3 and adult team has 3 as well. Part of the SWAN clinic means that we're able to offer these patients additional testing that haven't been offered through traditional NHS routes. So that includes investigations that were not previously considered or available because, as we know, time has moved on and the genetic tests available have grown considerably. We can also, as of now, offer reanalysis of existing data, and we also offer entry into possible research studies. The clinic takes a holistic approach to these patients. So the nurse specialists undertake holistic needs assessments. We signpost to different charities and support groups, and we try and offer some logistical support as well as some care coordination. So this is our referral process. As you can see, someone can get referred in, and then The referral's triaged by the initial MDT. We just note the referral letter and have a brief look through their medical history, and we decide whether we'll accept them or not. If they're not accepted, then we'll respond to the clinician that referred to them and offer some advice about next steps for the patient to work through. If they are accepted, then they're added onto our triage list, and then the clinical fellow is responsible for gathering all the information, their investigation results, literature, and then we'll present that back to the MDT. Once the MDT's had the presentation back, we then again decide whether we'll continue to accept the patient or actually, on further analysis, they're not a suitable patient for the SWAN clinic. So then they'll either have an advice letter sent back to the referring clinician, or we accept them onto our system. If they're accepted into the clinic, the clinical nurse specialist will then make contact with the family, will explain what the SWAN clinic is, get the hopes and aims for the family about being within the clinic, but also set some realistic goals and boundaries. We're not promising that we will get everybody a diagnosis and sort of fix everything that they feel is wrong with the system, but we will try our best to try and coordinate everything. We'll also take a family history, and then we also conduct our holistic needs assessment here. At the MDT discussion as well, we'll decide whether the patient needs to have some further investigations before we offer them a clinic appointment, or if we offer them a clinic appointment straight away and then make a plan from there. When the patient comes to the clinic as well, we also give a patient-reported outcome measure questionnaire, and these are given just as we see the patient in clinic. We repeat them at 6 months, and then we repeat them again at discharge, so we can evaluate whether the clinic's been a success for the family or not. Sometimes we'll get a diagnosis with these patients, at which point they're offered a review appointment with the family, and then that's with the whole team. And then following that, we'll offer a follow-up appointment with the genetic counsellor and the nurse specialist, just to sort of debrief from that complex appointment. And then unfortunately, if there are times where we won't make a diagnosis, but again, the follow-up appointment is offered with the genetic counsellor and clinical nurse specialist, so we can signpost them to how their care should be planned in the next few years. So the role of the clinical nurse specialist is quite unique to our clinic. So we offer care coordination, we offer emotional support, we signpost to a lot of services, and we can act as the source of information both for the family but other clinicians. We're advocates for the patients, and we're a point of call for families and clinicians. And we're also the link between the SWAN clinic and their local teams, which may be in other hospitals or areas of the country. This is our holistic needs assessment that we offer all of the families. It does look quite basic, but this is the basis that we as nurses base all of our care on. But this is not specific just for the patient. This is for the whole family system, whoever's involved in looking after that family. So we ask about physical health and emotional health. In paediatrics, we ask about education, and in adults, that's swapped for work or vocation or education if they're in higher education. We talk about their housing, their finances, ensuring that they're accessing all the right benefits. We see what current groups they're aligned with. Do they currently access any support, any charities, any sporting activities? And from here, we can make a plan about where the family feel there are weaknesses in their current support systems and how we can help improve them. So just a couple of case studies about how that's worked in practice. So the B family, their actual hospital care is already really well coordinated, and the family have appreciated having someone that can act as a point of call rather than having to phone all the individual medical teams. But for this family, it was more the mental health side of it that's been a real difficulty the past 6 months. For their daughter, we've managed to signpost her into a sporting activity where she can meet peers of similar abilities, and that's improved her mental health. Their son, who's also in a wheelchair, was just about to start primary school, so he's been referred into early years provision, and they'll support the transition from nursery to primary school. And more recently, we've referred the family into the early help system. So this will involve putting the family on any relevant courses and look at putting preventative measures in place for the family rather than waiting for something to go wrong and then us trying to help them. And as they're a family of 3, 1 in a pushchair and 2 in a wheelchair, we're also helping them apply for one of these whizzy bugs so that the youngest son still has some independence. And if mum wants to take the children out on her own, it's still possible. So the K family, they reported that they had a lot of lost medical appointments and they were beginning to start the transition from primary school to secondary school. So we followed up on them and they've had all of those scheduled back in. We've also been chasing where they are on waiting lists, and actually that's resulted in them being called for their interventions quite quickly. And we've also been involved in moving some of their hospital appointments to coincide with each other on the same day rather than them having their appointments on different days. We've also signposted them to it's a charity called Whiz Kids for a custom wheelchair. This little boy is very short in stature, and unfortunately every wheelchair he's been given by the NHS has not allowed him to be as mobile as he should be and not have the independence he deserves. So this charity build custom wheelchairs, which will hopefully improve his care. And the family also know that they can just phone me if they're not sure who they're meant to be phoning, or they don't know where they are in a system, or they just haven't got a contact number. They just call me and we work through that together. And then the M family, this is a lot of emotional support for this family. We have weekly to fortnightly phone calls, and I almost act as the sounding board for mum. Again, this family's been referred into the Whiz Kids charity as we've got 2 teenagers who are in manual wheelchairs, but as they're sort of reaching 14, 15, they'd like some independence. So we've referred them to have some electrical adaptations for their wheelchairs, which will allow them to go out and about without the need for support. They currently have a Motability vehicle and mum has issues with that, so we've been helping look into that. And there's been some issues with past care, so we've been helping mum work through that. I'm also the link between Cardiff and Vale and all their other health teams, their school, their community nursing and psychology input. Mum really struggles with care coordination on her side because she has ADHD, so I'm there to act as a support and help her keep check of all of her appointment times and make sure that we're in the right place at the right time. And then the BR family, their care's relatively well coordinated, but they live quite far away from the tertiary centre, about 2 hours, though we've supported in arranging some of their tests locally rather than them travelling down to us. We've been responsible for linking in with those local teams to coordinate it. And then the SWAN team have also helped write disability living allowance, which is the benefit for the family, a supporting letter for that and a supporting letter for housing and chasing up some lost medical appointments as well. So in the paediatric department, to date, we've had 59 referrals, of which we've accepted 45, so that's a 76% acceptance rate. On average, our patients have 188 investigations, but as you can see, some of them have gone up to 857. The amount of teams or specialities involved per patient is 8. And the average amount of both admissions and outpatient appointments is 55 for our patients. 39 of our patients still have ongoing investigations, including reanalysis, clinical trials, and clinical investigations. And so far, 4 of our patients have confirmed or expected diagnosis made, which is a yield of 9.8. But I will just say that was before we were able to offer reanalysis to a lot of our patients. Now we've had that finalised last month. We're progressing with that. And hopefully it'll be more. So in summary for paediatrics, our patients are varied and complex patients. They're clinically and genetically well investigated, especially compared to adults. And we don't feel that there's currently been any misdiagnosis. Our patients have attended vast number of outpatient appointments and have had very little care coordination. And because of the way the health service is set up in the UK, a lot of our patients have had to go across to England for specialist service review. So some of the positives that we've managed to take from the clinic so far is the benefit of service to review the entire medical history. We're able to answer held on to questions from the family, and the patients have appreciated having a face-to-face clinic appointment where both clinical and genetic staff are involved. The clinical nurse specialist has been able to coordinate care, and some medical teams have been able to provide strong input into our service as well. Our challenges moving forward are we've had a little drop in new referrals, so we're currently working out how we can maintain our referral system. Up until recently, we had no formal framework for reanalysis of previous genetic tests. There's been no universal buy-in for the system. There has occasionally been some potential safeguarding or diagnostic disagreement issues. And also, what if a diagnosis isn't made? That doesn't change anything. And up until recently as well, we had ongoing funding decisions. The adult department, their patients are very complex. Their presentation is complex due to different comorbidities, aging, and some environmental factors. There's a larger pool of differential diagnosis and a different diverse causes as well. So they could be genetic and non-genetic in origin. There's a lot of specialist involvement in that adult team compared to ours. There's a need for involvement not only just in the diagnostic arm of the clinic, but also treatment decision and ongoing care. And so far, they've reported that the services have been lacking care coordination, transitional services for these patients were poor, and a holistic approach has typically been missing within adult care. And they also have limited access to research and expertise in comparison to paediatrics. There's some of the unique challenges that are present within the adult system. There's a thin line between patients with syndromes without a name and then unexplained medical symptoms, and also an element of functional overlap between their symptoms. In mitochondrial disease, there's a necessity for more input from experts within this service, both nationally and internationally. There's a high demand for dedicated psychological support as well, specific to these undiagnosed and rare disease patients. And they need to have more exposure to the wider specialities. There's been very little buy-in from haematology and rheumatology, and also the wider geographic areas within Wales. And also we have some in-house limitations, especially with our clinical testing. So we need to have a more robust and streamlined pipeline for reanalysis and genetic data, and also how we can access further functional studies for these patients. And again, relating back to service sustainability, we had to ensure that we received further funding to ensure that we could continue running. So some of the things that have worked well for us, we've managed to do really well at networking, and that's both with experts in rare disease, organisations and charities, both nationally and internationally. And some of those have allowed us to be able to offer novel diagnostic tests and some personalised medicine to patients. We have a very good MDT approach. We're seen as a one-stop service for MDT members, and because we have input from genetics and bioinformaticians as well, it's received well across the rest of the hospital teams. Again, like I said, the specialist nurses are unique roles, and also our clinical fellows are very unique, and we've had some very good feedback on the work that they do. And this allows us to provide complementary holistic care. Unique to the SWAN clinic in Wales is the use of Welsh Clinical Portal. This is an online medical record, so we can see all of our tests and investigations and documents from patients all across Wales, which has allowed for effective data collection and monitoring. And we also collect patient-reported experience measures and patient-reported outcome measures. So we've used the existence of validated patient outcome measures to help evaluate our service. And again, we've got specialist clinical input. So we have very strong input from immunology, metabolic and neurology teams.
Thank you so much for that, Zoe. I'd like to open the floor to the people in the audience to whether anyone has any questions for Zoe about her presentation. Yes, Sue.
Thank you, Zoe. That was a really informative presentation. Just a couple of things. How long do you kind of provide support to your patients that have come through the service? Do you kind of have a cut-off date, or do you just stay accessible for kind of telephone calls or phone support afterwards?
Until they're discharged from the clinic.
And
so as long as that.
Do you discharge them once all the investigations have been completed and you either have a diagnosis or you don't?
Yeah, so to date, we haven't discharged very many people. There's a couple of people that have been discharged with a diagnosis, and I think only one or two that were discharged without, but that was prior to me starting. Since I started, we haven't actually discharged anyone, mainly because we were waiting for our reanalysis pipeline to be confirmed. So now that that's up and running, we will start tailoring off support. But my view is that if we know that that's coming, then I'll sort of get a plan in place for these patients, work out where they feel their issues still are, and we can look at how they'll be addressed moving forward, with the view that my support will start being withdrawn from them.
Thank you for that. And my other question is, if you had more funding, what would you actually want more of? Or, so for example, would you want more nursing, more medical? Would you want disability coordinate? You know, what would you, if you had more money, what would you do with it? How would you reconstruct your model or add to it?
I think from a nursing side of view, I would like to be able to open up my role to families that aren't referred into the SWAN clinic, because I feel like my support is I can only provide my support to the patients that want to go through almost this diagnostic odyssey again. Do they want to sit down and revisit everything that's happened to them? And do they want to have further investigations and be sort of in that area of uncertainty again? But for the families that have just sort of said, that's it, they're happy with their child, how they are, or the adult patients, they don't want to go down that diagnostic pathway again, that they're still in the same situation as everybody else. They still have poor care coordination, they still have difficulties accessing their disabilities, but we can't provide that service to them unless they agree to come into the SWAN clinic. So I think that's my view, is that maybe we could have more care coordinators for everybody who has a rare and undiagnosed disease, rather than just the patients that come to us for a diagnosis.
Great, thank you. Thanks, Zoe. That's awesome.
Thanks for that question, Sue. I've just got a couple of questions in the chat, Zoe. I've got one from Dion. Is it a short-term service, which you kind of answered from Sue's question of when you discharge? But Dion would also like to know, how much FTE do you have for your CNS roles?
So it was a 2-year pilot, and within that, our funding for the nurse specialist I was full-time and the adult nurse was full-time. Our new funding model is just for 12 months, and I think that that's going to slightly reduce, with myself and the adult nurse reducing down to part-time, so maybe 2.5 days a week. But we're still working through the exact funding model, but yeah, we will be reducing our hours.
Okay, thank you for that one. And then we've also got from Faye, how do you go with collecting feedback from families? Are they reluctant at the end of the journey to give you feedback?
So we have the patient reported outcome measures, which are given pre-clinic, at 6 months, and at discharge, and they are sort of agree, disagree questions about how they feel their health is managed and their answers. And we do have a Likert scale at the back of 0 to 10 of how they rate the SWAN clinic, and there's also a free text box that they can give us some feedback if they want to. And then we also have some experience measures at discharge. At 6 months, we do also invite everybody to an interview with a researcher, but we haven't had a very good uptake on that yet. But since we've introduced the PREMS and PROMS, we actually haven't had anyone at the end of their journey. So we've only got the 6 months data at the moment.
And have you been able to successfully get a high input from your patients and families at that 6 months, or have majority of them said, no, thank you?
No, everyone that I've asked in paediatrics has completed the questionnaire. I do it with them over the phone if they're not on site, and adults, it's sent out through the post, and I think they've had a pretty good return on it.
Okay.
It's all in write-up at the moment, so I haven't got anything to actually
No,
feedback to you, sorry.
That's okay. No, that's fine. Another question from Tessie. What does good care coordination look like for your families?
I think for my families, the way they've defined it is sort of having me as a resource. That's what they found most valuable, is they know they can just pick up the phone to me, and if I'll go and try and help them with whatever it is. Sometimes it's just they need that emotional sounding board because it's been a tough week, or they've tried to get hold of one consultant and it's been 2 days and they haven't heard and they're worried. So I think it's very different for all of my families, but I think for them it's just knowing that they've got someone that's aware of that overall picture and can help them with the little stumbling blocks that to most clinicians aren't a big deal because they're very minor, but actually for that family, that's the thing that's going to be a big thing for them that week, and actually just ironing that out will make their life a lot easier.
Amazing, thank you. We've got a couple more questions coming.
I have a question, Sean.
Oh, go for it, Kayla.
Zoe, you talked about looking to increase your referral rates. Do you have any plans around the strategies that you'll use to increase referrals?
I think it's just going back out and communicating about the SWAN clinic. We weren't allowed to do much communication or sort of publication about it because we didn't know if we'd have continued funding, so we didn't want to advertise it. People get referred in and then we say we can't take your referral, because that also sends mixed messages. So now we're able to go back out with those strategies and do them.
Oh, great. That's great.
Awesome. We've got a question from Zora. Do you follow any specific care pathway in the clinical setting that you follow in terms of maintaining phenotyping, pedigree, referrals, and genetic testing results? That also includes the holistic care plan for families.
So the holistic assessment, every family gets offered that once they're accepted into SWAN. That is part of our pathway, which I'm quite proud of, because I haven't found many, if any, clinical pathways that actually have a holistic element embedded within them. So we were very keen to make that as part of the pathway. Everybody has that. But all of our patients are so different that we haven't really got a set pathway. Once they're referred into clinic, it patient dependent, depending on the previous tests that they've had, especially for adults. A lot of them haven't had any sort of up-to-date genetic testing. It might have been 20, 30 years ago since they saw genetics. So it's very hard to put a specific care pathway in place when these patients are just so different. And especially for paediatrics, we found a lot of them have already had a lot of the genetic testing. So actually, you could almost say in paediatrics, most of ours go down the reanalysis pathway, but that's just because of the type of patient that is referred in to us compared to adults.
Amazing. Thank you very much. I think we will wrap up today's webinar there. I'll just share our QR code for anyone who is attending or watching the recording that hasn't signed up yet. Please use the QR code to register for the Global Nursing Network for Rare Diseases. And like I said, this was the first webinar of the series. We'll be doing these throughout the year into 2024. So please watch out on our homepage for upcoming events. And thank you all for coming tonight. I really appreciate your time. Thank you, Zoe, again for presenting. It was a wonderful presentation.
No, thank you for asking me.
Thank you. Thanks, everyone.
Thanks, everyone. Have a great night. Have a great day wherever in the world you are. Appreciate you all. See you soon.